So I'm going to speak about the dilemma of mode of delivery and long-term pelvic floor dysfunction. Only a patient-informed choice. Future pelvic floor dysfunction and sexuality is a concern for many pregnant women. Birth-related pelvic floor trauma is much more common than previously assumed. An increasing concern among women and urogynecologists about long-term consequences leading to increasing need for surgical repair. But these problems are still ignored in antenatal consultations with obstetricians and midwives. We now know that during the second stage of labor, damage to the pelvic floor, its muscles, nerves, and endopelvic fascia often occurs due to stretch, compression, rupture, denervation, and ischemia. We also know that there is an overwhelming evidence about the detrimental effect of vaginal birth on future pelvic floor function. This evidence comes from epidemiology, pathophysiology, and imaging using modern techniques like ultrasound, MRI, manometry, and EMG. However, for ethical reasons, randomized control trials will never be done. Large epidemiological studies such as EPINCONT, PROLONG, and SWEPOP all show a marked increased risk for all major PFDs, especially the combination of PFDs after vaginal birth compared with a caesarean section. From Sweden, Stockholm, Leijonhufvud et al. Have published that the need for surgery for prolapse increases dramatically with time since first vaginal birth, whereas the need for surgery is very low after a caesarean section. As opposed to odds ratios, the prevalence is a good measure which is easy to understand for the general public. Any pelvic floor disorder and urinary incontinence affects nearly every second woman 20 years after one vaginal birth. Pelvic organ prolapse and fecal incontinence and combination of PFDs affects nearly 15% of the women. MRI studies by the Delancey group have shown levator ani muscle injury in one pair of women, up to 10% after a normal spontaneous vaginal delivery, up to 33% after a vacuum extraction, and up to 71% after a forceps assisted delivery. This was not identified in oviparous women or after a caesarean section. These data has been confirmed with ultrasound by Dietz group in Australia. Today, total fertility rates are declining worldwide. As opposed to a century ago, women of today give birth to 1 or 2 children. This is important when we consider consequences of the mode of delivery. To further illustrate this, that Japan's birth rate is so low that adult diapers are sold more than baby diapers. One important problem is that obstetricians and midwives drive for vaginal birth regardless of women's concerns. Anxiety, fear of pain or pelvic floor laceration, and unwillingness to undergo vaginal delivery. Permanent deterioration on pelvic floor function and sexuality not considered. And that 1 or 2 births is the only option for the woman. The consequences of this policy, that CS rates need to be lowered at all costs, will lead to increased use of instrumental delivery, accepting longer second stage, and to push for vaginal birth after caesarean section, which in all are known to increase the risk for perineal lacerations, sphincter ruptures, and levator muscle injuries. To illustrate this with data from the Swedish Medical Birth Register from the last 25 years, instrumental delivery, forceps vacuum, and vaginal birth after CS are associated with extremely high rates of sphincter injuries, between 10 to 25%. Another problem is the prevalent use of excuses for not targeting vulnerable groups with unfounded notions such as, if the damage already is done, it can't get worse, or it's because of the pregnancy and has nothing to do with mode of delivery. And there are effective quick fixes that cure PFDs for good, which always aim to recommend vaginal delivery as a problem solver. Well, how dangerous is a caesarean section, a planned caesarean, compared with a planned vaginal delivery? NICE guidelines from UK have published a systematic review about the risks. And first of all, they found from multiple studies that there were no study with high quality of evidence. Most studies were very low quality of evidence. They found that in the planned caesarean group, there were less perineal and abdominal pain during birth and 3 days postpartum, less injury to the vagina, less early postpartum hemorrhage, and less obstetric shocks. In the planned vaginal delivery group, there were shorter hospital stay, 0.6 days, less hysterectomy due to postpartum hemorrhage, although very low numbers, less women with cardiac arrest, and less visits to neonatal intensive care unit. They found no difference in outcomes such as injury to bladder, ureter, cervix, pulmonary embolism, wound infections, uterine rupture, assisted ventilation, and so on. And there were conflicting findings from studies concerning maternal death, deep vein thrombosis, blood transfusion, infections, anesthetic complication, neonatal mortality, and Apgar score at 5 minutes lower than 7. So what are the motives for limiting elective caesarean section on maternal request versus maternal autonomy? Well, there's a lot of professional interests, and there are economic interests. Healthcare planners, politicians, and economists want to limit immediate costs from the delivery departments, not taking pelvic floor disorders into account and how to treat them later on. And there are a lot of idealizing the notion of the natural birth, and there are a lot of scare tactics about caesarean. And there are also paternalism. However, in this respect, it's important to note that there are potential risks associated with repeat caesarean sections, above all placenta accreta, and that risk increases for every caesarean. So for women who want a big family, it's not a good option with elective caesarean. So what about childbirth autonomy? According to the Supreme Court in UK 2015, in the case Montgomery versus Lanarkshire, they said that when there are options in care, the patient decides, not the doctor. If a caesarean is a reasonable option, women are entitled to choose it. And medical paternalism is no longer acceptable. Doctors must be guides in providing care and not leaders expecting obedience to their personal judgment of what is appropriate. So I think globally we must act for growing empowerment for women, politically, economically, socially, culturally, legally, and also medically. Thank you for listening.